Well, we're seeing you for an abdominal concern for an abdominal wall defect, and that can be two categories. And when we say abdominal wall, it refers to the front part of the abdomen around what we think of as the belly button or the umbilicus. And there's two general categories. One is called gastroschisis, when the bowel is outside of the abdominal cavity and it's just free floating out in the amniotic fluid. The other type of abdominal wall defect is called omphalocele, and that has a very thin, fine membrane covering it. The bowels are almost pushed out into the bottom of the umbilical cord. And it's pretty reliable that your ultrasonographer or your maternal fetal medicine specialist has been able to help us identify which type of defect your baby would have. Well, with each of these, we would separate them out because they both have very potentially different management strategies. So if we're talking about the gastroschisis, that's something where the pediatric surgical team is present essentially in the delivery room with a neonatologist. We make that commitment whether or not the baby's born vaginally at 3 a.m. or if the baby is born by a planned cesarean section, that we're there at the time of delivery so that we can assess this, ensure that the diagnosis of gastroschisis is correct, and then be able to help manage the newborn baby with the neonatologist, with us paying particular attention to the bowel to make sure that it's healthy and pink and viable, and then we can make a plan for performing some type of closure of the abdominal wall defect. So we're there right in the delivery room, and then would assist in transport of the baby over to Children's for more definitive management. With gastroschisis, I tell most of the parents, most of our families, we can make a guesstimate whether or not we think we'd be able to tuck everything on the inside and do what we call a primary repair, or repair the defect right at the time of birth. That's always our preference if we're able to. The alternative, if we're not able to primarily tuck everything in and perform that primary closure in the operating room, is to place what's called a silo. And that is a little piece of clear plastic that we just put through the little opening so that the intestines are up in a little silo or chimney. And then every day we just gradually reduce that over time, usually the first week of life or so, 5 to 7 days. Until then we can go to the operating room and perform a definitive closure. Even though the intestine is tucked in on the inside, there's some bowel damage that occurs, and I like to separate that really into two different categories. One is how well the bowel absorbs our nutrition, and the other is the motility, how well it pushes the food along the gastrointestinal tract. Sometimes the bowel can be shortened and cause a short bowel syndrome, or sometimes the function is just not normal. And so we anticipate a period of bowel adaptation. That period of adaptation, if you look at all comers, averages out to be anywhere between 4 to 5 to 6 weeks in the hospital. So we found that it's extremely helpful to meet with us, meet our team, take tours of Children's Hospital, because it's a situation where you don't frame around weeks, but you can kind of frame around months. And that really, I think, is helpful when families are making plans around the time of delivery, to know that even though we don't anticipate a baby to be critically ill during that whole time, that they will be in a hospitalized setting, for a medium term or what can feel like a long-term interval while we're going through that period of bowel adaptation with gastroschisis.